Thank you, Dr. Grady. Dr. Kearney, members of council, and guests, it's a pleasure to provide you today with an update on NINR's End-of-Life and Palliative Care portfolio and the Office of End-of-Life and Palliative Care Research, or OEPCR. So what we're going to talk about today is focusing on NINR's end-of-life and palliative care science, some of the thematic areas of research that we have across our end-of-life and palliative care portfolio, and palliative care research examples and the impacts of NINR's leadership in the field of palliative care science. As the lead institute for end-of-life research at the NIH, NINR targets research efforts to assist individuals, families, and healthcare professionals in managing the symptoms of advanced illness and in planning for end-of-life decisions. OEPCR also coordinates and supports efforts to improve advanced care for those with serious illness. Some of the thematic areas that we address in the Office of End-of-Life and Palliative Care range from relieving advanced symptoms, enhancing communication, understanding decision-making surrounding advanced illness and at the end of life, and addressing the unique challenges, barriers, and experiences by individuals of all ages who are facing serious advanced illness, and building the next generation of end-of-life and palliative care scientists. All of these areas are really cross-cutting and can be applied across the lifespan, across different ethnocultural groups, and in different disease conditions. To fully appreciate the work that our scientists do, it's important to have a shared understanding of what palliative care is and the benefits and values it provides. The IOM report, Dying in America, defines palliative care as care that provides relief from pain and other symptoms, supports quality of life, and is focused on patients with serious advanced illness and their families. Within this definition, there are certain key points that really shape our research approach. These include that palliative care is both individual and family-centered, that it integrates psychological and spiritual facets of care, including the impact of social determinants of health in all aspects of care, that it is interdisciplinary and requires an interdisciplinary approach to addressing these individual and family needs, and that palliative care occurs throughout the full trajectory of disease, from diagnosis through grief, bereavement, and loss.
To share with you how we will integrate these themes into end-of-life and palliative care science at NINR, we will present highlights of work currently underway in several of our thematic science areas. We will provide you with information on the goals, targets, approaches, and preliminary findings, and while we will not discuss methodology in depth, we will highlight the important work being done and the impacts of these ongoing studies in the field of end-of-life and palliative care science. Pediatric palliative care is unique in that it spans a very dynamic time period in life from infants to adolescents and young adults. Children experience a variety of complex illnesses that are not usually seen in adults, and these illnesses can act differently in children due to their unique anatomy and physiology. Often in pediatric palliative care, the illness trajectory is unpredictable. This adds the burden of uncertainty to an already stressful situation. Care must be considered in the context of the impacts of the illness on siblings, peers, and the ability to go to school. Therefore, there is a need for interventions that incorporate the voice of the child when parents and guardians are making decisions about medical care and planning for the future. The target of Dr. Maureen Lyon's current study is understanding the needs, perspectives, and decision-making processes of teens with advanced cancer and their families. The goal is to create an effective end-of-life and palliative care advanced care planning intervention for this population. What is somewhat unique about this study is that Dr. Lyon's approach includes ethnographic features, such as urban versus rural, gender, race, and that the intervention is conducted with both the parent and the teen. Through a series of 3 sessions, the intervention educates parents on how to have conversations about advanced illness with their teenager. It also educates teens and gives them an opportunity to share their preferences, goals, and values. In this way, they also have a voice in their future medical care. This unique intervention occurs in the context of exploring the factors that influence how choices are made. While this is an ongoing study, Dr. Lyon's research has already made an impact. Her work was recognized during the March 2018 Annual Assembly of the American Academy of Hospice and Palliative Medicine and Hospice Palliative Nurses Association during the State of the Science plenary as one of the 7 most clinically important research publications in end-of-life and palliative care. Already, her work has uncovered some of the missing pieces to the puzzle of how to approach advanced care planning in teens with cancer. Her study has discovered that the intervention engaged parents to ask more questions, to discuss advanced illness more in depth than they would have otherwise. Teens were empowered to communicate their wishes for their own end-of-life care to their families, and the families verbalized a commitment to honor their requests. Families felt better informed when making decisions, and family-centered advanced care planning provided an environment in which families could listen to their teens discuss their fears, hopes, and preferences, which in some situations includes discontinuing unnecessary and unwanted care. By the end of the study, the PIs also anticipate identifying ethnocultural differences in response to the intervention. But we need to do more. We need to know what factors are most important to teens when making end-of-life advanced care decisions, and how these factors might drive the differences observed in response to the intervention. Our next thematic area is caregiving throughout the trajectory of palliative care, including the end of life. The majority of end-of-life care is provided by caregivers, families, and friends, 9 in 10 of which are unpaid, yet they provide greater than 21 hours of care per week in high-burden situations. Consequently, these caregivers are more likely to report a decline in their own health, and this is a widespread problem as 36% of seriously ill individuals receive home-based palliative care and 56% nearing the end of life are in home hospice care. However, if adequately supported, family caregivers can succeed in their aims of meeting the needs of their loved one. Therefore, it is important that we look to research projects with the potential to translate and adapt palliative caregiver support to the settings where care is received, including the home. For example, nurse scientist Dr. Betty Farrell has created and refined a lung cancer palliative care intervention called PCI, which she has tested through multiple NIH-supported randomized clinical trials. We know from the randomized clinical trial findings that PCI significantly improves quality of life and spiritual well-being, decreases symptoms and distress, and increases the use of palliative care. The target of the current study, however, is focused on how do we translate and implement this successful intervention from a controlled clinical research setting into a large community-based healthcare system. The goal is to conduct a pragmatic clinical trial where the PCI, which was previously delivered by members of a research team, would now be delivered by community Kaiser healthcare staff. And this boots-on-the-ground approach is facilitated by her co-investigator and Kaiser nurse and implementation scientist, Dr. Wen Hong. Within this approach, key components of the intervention remained the same: a comprehensive family assessment of needs, the creation of a tailored care plan, and education for both the ill individual and their caregiver in how to achieve their goals of care. The pragmatic design component uses the Kaiser health care teams already in place in these locations to conduct the intervention. Early results of this study have shown the PCI has been successfully taken up by medical oncology and palliative care teams, and ongoing support has been shown for further integration of the PCI. Moving forward, studies like those of Dr. Farrell, which take randomized control trial designs and translate them to community through pragmatic designs, need to be expanded. However, Dr. Farrell's findings have provided insight that expanding the reach of home-based palliative care must occur within the consideration of local structures, processes, and contexts within the community healthcare system. Now I'm going to shift gears again to communication in palliative care and end of life. We know that the effective communication with patients and families is one of the biggest challenges when providing care for those with serious advanced illness and at the end of life. The IOM Dying in America report stated that engaging people in defining their own values, goals, and preferences concerning care at the end of life and ensuring that their care team understands their wishes has proven remarkably elusive and challenging. Therefore, strategies to improve communication must include identification of strategies to facilitate, understand, and communicate advanced care planning goals. To address this issue of communication during palliative care, Drs. Michael Pash-Orlow and Timothy Bickmore have combined their expertise in palliative care and computer science. Their target is to understand how emotions affect and drive the decision-making process. The goal of this study is to adapt an existing technology, a conversational agent, for individuals in the process of making decisions in advanced illness. So they call the interface the ECA-PAL, which stands for Embedded Conversational Agent for Palliative Care. The approach they are using is depicted on this slide. On the left side, you can see that the ECA-PAL is an interactive computer interface which has an avatar, which asks questions, and as it does, it expresses emotions, mimics normal nonverbal behavior, and the avatar guides the conversations about topics such as taking medications, advanced symptoms, side effects, stress, physical activity, etc. The avatar is connected to the database via Wi-Fi. In the middle, you can see there is a nurse on the other side of the interface who monitors responses, and when necessary can respond by making appropriate referrals to the palliative care team or the primary care physician. In addition, the caregiver also has access, and they can also review the interactions. These investigators are taking on the elusive and challenging issue of palliative care communication in a whole new way, with teams that integrate both palliative care science and technology. Dr. Pash Orlo, when asked about how technology was received by patients, said that they were very comfortable and accepting of the concept. It even got them thinking about questions that their doctors had not yet approached them with. In the World Health Organization 2004 report, a quote by Cicely Saunders, the nurse who founded the modern hospice movement, reminds us of the importance of understanding diverse populations. She said, palliative care begins from the understanding that every patient has his or her own story, relationships, and culture, and is worthy of respect as a unique individual. This statement encompasses an important gap area in our portfolio, which we are addressing through the efforts to focus research on diverse populations with different ethnocultural backgrounds and within diverse geographic, regional, and healthcare settings. We know that diverse populations are more likely to die in an institution, less likely to receive adequate emotional, pain, symptom support, or receive care consistent with their wishes. They are less likely to receive adequate support or care in hospice, and also have poorer communication with providers, leading to greater misunderstandings about care options. So cultural barriers increase disparities in palliative care, and it is clear that we need interventions that address these barriers within individual communities. So Dr. Stacy Fisher is investigating these issues of diversity in a palliative care with her study Apoyo con Cariño, which is translated as support with caring. The target of this intervention is to study and test a culturally tailored community-based intervention that facilitates palliative care for Latinos with advanced diseases. The goal is to identify and address the barriers to care in urban and rural communities. And the approach involves the training of community Gaia navigators to support advanced care planning, advanced symptom management, and hospice care, while providing emotional support in a culturally and linguistically sensitive manner. Gaias are bicultural, bilingual lay people with a healthcare background that are embedded in the participating community sites, and as an example, some of them are medical assistants, healthcare aides, and one is an MD from Mexico who is not currently practicing in the United States. So just to provide an example of the preliminary results from this study, with advanced care planning, individuals in the Gaia intervention group, shown in orange, when compared to an attention control group, completed more advanced directives, were more likely to discuss future healthcare preferences with their family, and spoke more often with their healthcare provider about future healthcare decisions. Therefore, in a broad sense, the relationships established between these Gaias and the patients and their families help to reduce the barriers to quality palliative care in both urban and rural settings. Therefore, this palliative care model has enormous potential to transform palliative care in other diverse populations. Other outcome measures included pain and symptom management, hospice utilization, use of aggressive care at the end of life.
We'd like to briefly give you a few examples of how NINR continues leadership in palliative care science through enhancing careers, strengthening our resources, and building the science. The OEPCR has focused efforts to build the next generation of scientists in end-of-life and palliative care, and to create opportunities for research mentoring and support in the palliative care community. Along with our training program officer, we continue to reach our goal to provide opportunities to build new leaders in end-of-life and palliative care. Listed on the slide, you can see several of our efforts in both early stage and mid-career end-of-life and palliative care awards. And we will be highlighting these a little bit later as you hear from Dr. Dion Odom. A second focus of OEPCR is to build an interdisciplinary scientific community that increases not only end-of-life and palliative care research capacity and capability, but also builds future leaders in end-of-life and palliative care science. Over the last few years, NINR has looked to strengthen this research infrastructure and the resources through supporting the Palliative Care Research Cooperative Group, or PCRC. The PCRC provides multi-site clinical trial capacity and expertise to conduct nationally scalable randomized controlled trials, a wealth of research, education, training, and development opportunities that are specific to end-of-life and palliative care research, and opportunities to obtain guidance in clinical trial methodology, again, that's specific to this area of science, looking at both design and instruments that are available. They also provide researchers access through consultation to the best scientists in the field who are willing to collaborate and help work on some of these unique multi-site designs, particularly in trials relating to palliative care. The PCRC has grown to more than 400 members at more than 130 clinical sites, and resources are available to build the science of palliative care, such as the Investigator Development Center, which sponsors pilot awards, clinical trial intensives, and webinars, which are archived. The scientific cores, including data informatics and statistics, measurement, caregiver research, and clinical studies and methodology. And the Project Coordinating Center, which coordinates the efforts of the many trials that PCRC is involved in supporting, including at the 27 PCRC-sponsored pilots, as well as numerous awards from other entities. The OEPCR continues to build the science of palliative care through new funding opportunity announcements that address important areas for the field. This slide gives you just a few of the ones, recent FOAs that have focused on some contemporary issues, such as evidence-based approaches that are appropriate for unique and understudied populations, such as adolescents and young adults and individuals with rare diseases, on end-of-life and palliative care interventions and models of care, and in increasing palliative care health literacy. In conclusion, we believe that NINR's scientific portfolio is changing the practice of end-of-life and palliative care and improving the lives of individuals with advanced serious illness and their families. We're committed to continuing NINR's leadership in end-of-life and palliative care science, and we look forward to continued efforts to build this important area of science.